Hello, my name is Rashida Shah, and I'm currently pursuing a doctorate in nursing practice with a focus on family practice. I'm working as a registered nurse, and I have a bachelor's in nursing and biology. Today, I'm going to be talking about the intervention for my clinical scholarly project, which is an educational seminar to promote diet adherence for adult hemodialysis patients. So first, I want to provide a brief background starting with the definition of adherence. Adherence to a therapy refers to the extent to which a patient is compliant to a treatment based on a health provider's recommendation. Non-adherence, which is not a patient not being compliant with health provider's recommendation, is common in patients with chronic diseases such as end-stage kidney disease. It can be intentional or unintentional, and several patient-related, disease-related, and treatment-related factors can cause non-adherence. Measuring adherence methods. Methods of measuring adherence differ in studies and include indirect measures such as self-reported adherence and direct measures such as counting pills or using electronic medication monitoring system. Also, measures such as weight gain or parameters such as phosphate and potassium levels can be used. The American Kidney Fund, in order to measure factors contributing to non-adherence and possible interventions to improve compliance, the American Kidney Fund conducted a 33-question survey for end-stage kidney patients. More than half, 58% of patients reported non-adherence to diet recommendations. The most common reason was lack of understanding or education of the prescribed diet and difficult to follow when dining out. So the stakeholders that I will be using for my clinical scholarly project include a registered nurse, a nurse practitioner, a dietitian, and a case manager. So the roles of the stakeholders differ. The registered nurse will be the one who will organize the educational seminar. So that would be me. I will be the DNP student / registered nurse who will organize the seminar, create a presentation and pamphlets, and that will reinforce diet education, benefits, consequences, along with what are the recommendations. And I will also instruct the listeners on the MyPlate app. I will work with healthcare providers. I will record and analyze collected data and distribute surveys. The nurse practitioner will communicate with patients, prescribe individual patient diet based on their background and history, educate patients on the treatment plan, and follow up and assess patients. The dietitian will be monitoring patients' diet and reinforcing what was taught in the educational seminar and adhering to the diet. They will educate patients on the normal amount of levels they're supposed to be intaking on a daily basis and assess patients' labs and needs for adjustment. The case manager will be the one who will oversee the patients and nurses and assess patients' labs daily to see if there's a need for changes in the treatment and communicate with healthcare team about patient changes. The patients will be adult hemodialysis patients that are over the age of 18 that will participate in the educational seminars. They will complete a pre and post knowledge exam, and they will adhere to the prescribed diet. So the theory that I'm going to focus on for this clinical scholarly project, and it will provide the foundation for this project, is the humanistic nursing theory. The theory was developed by Josephine Patterson and Loretta Zadard. This theory can be described as a multidimensional and interactive theory. It involves two components: the human or the patient's family and community, and the nurse. The theory promotes viewing the patient as a whole and seeing the patient as not just as a number, but as an individual. And it focuses on developing an interpersonal relationship with the patient and gaining the patient's personal and emotional perspective. So basically, during the educational seminar, the nurse practitioner, nurse, dietitian, and case manager will be working with the patients and receiving feedback from them in order to customize their diet plan and also establish the reasons why they are not adhering to their diet. There are 3 components to this theory. So these include dialogue, community, and phenomenological nursing. So dialogue involves person-to-person dialogue, and dialogue can occur in a group setting involving feedback that instructor may receive from learners. So while the educational seminars are taking place, the educator will receive feedback from the learners to see if they are obtaining the knowledge, and also the reasons why they are unable to adhere to their diet, and what kind of learning style would work best for them. And then based on that, the educator will make adjustments in order to improve the seminars. The next thing is community. So community is basically involves a group which learns the reasoning for their actions together and share viewpoints and experiences. So I want the educational seminar to be interactive, so each patient can share their viewpoints and their perspectives. And finally, the third component involves learning other experiences without judgment, understanding others' viewpoints, analyzing experiences, synthesizing information gained, and using ideas acquired from each situation. Educators can develop and define their relationships with colleagues and students to help structure the teaching methods and interventions. This theory serves as a framework because it will make stakeholders develop an interprofessional relationship with patients and find motives behind lack of adherence to diet. Also, it will allow for the creation of an individual diet plan and consider patients' backgrounds when creating this plan. Lastly, it will guide the educator on how to teach effectively in order to improve adherence, and data will be analyzed to reveal if interventions improved adherence. So moreover, when deciding on using an educational seminar as my intervention, first I looked at factors that contribute to non-adherence. So first, level of education has been cited to correlate with adherence behavior in chronic illnesses such as chronic kidney disease. Low education results in decreased adherence due to poor correlation with knowledge of disease and treatment. Knowledge appeared to be the main facilitator of positive adherence to fluid restrictions, with the correct self-assessment and supportive social peers also playing a role. Low health literacy. Low health literacy has been found in dialysis patients, and this factors along with regimen complexity leads to non-adherence. These with low levels of health literacy find it hard to follow instructions on how to care for themselves or to comply with treatment, such as taking their medications and prescribed diet. Also, language barrier can be a factor for non-adherence. Around 33% of healthcare providers cited language barriers as a cause for patients missing dialysis appointments, and 24% of providers found that language barriers inhibited end-stage kidney patients from asking questions about their treatment. This reveals a need for better, culturally relative patient education in multiple languages and making sure that providers have the resources they need to adequately support patient adherence. So another thing that there were some studies that proved that education serves to improve adherence, and this served as a foundation for the CSP intervention. A systematic review was done using 36 randomized controlled trials. Education, counseling, and psychological interventions were used, but educational sessions were the main source of interventions in all the studies, and it's a result of these educational sessions, there was improvement in weight outcomes. Also, as mentioned before, the American Kidney Fund did a 33-question survey, and they found that 56% of patients preferred printed health materials, 53% preferred planners or calendars, and 24% preferred mobile apps. Two other studies that revealed how education can improve adherence. First, this quasi-experimental study was done and to improve adherence to fluid and sodium restrictions. 45 patients were used for the study for 6 months. 3 consecutive educational sessions were done for 30 minutes, and educational intervention led to increased adherence. Also, a study that was done with 20 to 30 minutes being added extra every month that provided education, and this involved 32 experimental group and 31 control group. Monthly blood samples were drawn, and as a result of these 20 to 30 minute extra educational sessions, there was increased knowledge and decreased phosphorus levels. So this slide explains the educational needs for the stakeholders and the patients. The stakeholders must be provided information on the purpose of the clinical scholarly project. This includes background information about the prevalence of non-adherence, the benefits of adherence and non-adherence, and the consequences of non-adherence. And next, the stakeholders will be told their role to help complete the project. A weekly email will be sent to stakeholders to explain the progress of the project and any new findings. And the stakeholders will be provided an evaluation and statistical analysis report along with the costs and benefits of completing this project. Patients will be educated on diet adherence, including the benefits of adherence and consequences of non-adherence. They will be told the normal fluid and sodium restrictions and what levels they should maintain for their weight and blood pressure. They will also be taught how to use the MyPlate app as part of their education. So this is an outline for the intervention. This is a randomized controlled trial that will take place over 3 months, and it will include 4 educational sessions. The first 3 sessions will take place the first day of every week for the first month. And then the final session will be the last week of the final month. There will be 30 adult hemodialysis patients used, 15 in the experimental group and 15 in the control group. And these patients should be receiving hemodialysis 3 times a week and have had dialysis for the past 6 months. There will be 3 educational sessions, as mentioned before, for the methods and 1 follow-up session. Each session will be 3 hours long. The information will be provided in English and Spanish, and stakeholders will be present for all educational sessions for at least 1 hour. There will be a pre and post exam. So the pre-exam will be the first session and the post exam will be on the final session. Presentation will be given through a screen and projector, and pamphlets along with sheets to follow along with the presentation will be given. The patient's weight and blood pressure will be obtained on the first and final day of the session, and there will be a MyPlate survey given on the final day, which will basically determine the level of use of the app and if the patients found it beneficial. Also, there will be a meeting, like a 10-minute meeting with the stakeholders every session, just to review what's going to take place and any new findings or changes. So the evaluation will be done through a pre and post exam, the results and the differences. There will also be analysis of the blood pressure and weight values that will be taken from the patients, along with the survey will be analyzed, and a statistical analysis will be done with a 0.05 less than p-value significance. The pre and post exam. So this will be used to assess the knowledge of the patients on their disease and their diet, assess their level of knowledge on how much fluid and sodium intake and they should be taking. And there will be 30 questions, and points will be given on terms of how correct the answer was. And there will be 10 questions for the survey with that will provide feedback to see if the MyPlate app was beneficial for the patients and their level of use, and that will use a scale from 0 to 5. This is a cost and benefit analysis chart. This basically tells the stakeholders how much time they will be spending and how much they will be paying based on average salary, the equipment that will be used, so the projectors, screen, pamphlets, and the questionnaires, along with the refreshments. And then the cost for travel is also included, and the final benefit would be $3,571.20. And then these are the references.